we're going to be talking a little bit about medication management for overactive bladder. Generally, I tell patients there's two main types of medications we use to treat overactive bladder. Without getting too deep into the chemistry of the different medications, what are the real differences that you see with the medications and how well they work for the average person?
So I think the two classes we're talking about, the anti-muscarinics and the beta-3 agonists, and I think the real differences come down to the side effect profiles. I think the efficacy has been shown in multiple studies at this point to be pretty similar between the two drugs, that being that they all show statistical significance every time we test them and marginal clinical significance. But the real side effect difference is the dry eyes, dry mouth, constipation with the antimuscarinics, and the possibility, albeit rare, for hypertension with the beta-3s and maybe some headaches with the Vibegron formulation.
How do you guys counsel your patients on the different side effects and what might be best for them?
So usually in terms of side effects, it depends on the class of the medications. As we had mentioned before, with the anti-muscarinics, there's dry mouth, dry eyes, constipation. There are certain contraindications as well. For many of the medications, if you have narrow angle glaucoma, that's a contraindication, or if your bowels don't move properly, like if gastric outlet obstruction, or you're not emptying well. For the beta agonists, people tend to have headache rarely, and it's possible to get hypertension. I always tell my patients when I start them on Beta-3, which has a higher likelihood of having hypertension, to check their blood pressure after 2 weeks.
Right. So it sounds like we kind of guide our patients based on what the different side effect profile is. If they're have a history of high blood pressure, if they have a history of headaches, for example. I've had patients who are like, I don't want to deal with that side effect because I already have headaches all the time, right?
Right.
Which medications do you personally choose and why?
I usually go with Mirabegron at a lower dose, 25 milligrams, because of the side effects, just slightly lower chance of maybe getting the high blood pressure. And Mirabegron, I send the generic just because there's two available Mirabegron drugs now, but it's not truly generic. So I let them know that there's a chance it could be a little costly, but we could try to do a prior authorization, and worst case scenario, we might have to switch to an anticholinergic.
Yeah. I find sometimes I'm prescribing based on what's on their formulary, not always able to give the drug I think is going to be most optimal for that patient. But we're balancing so many things, right? And a lot of what we're balancing is the financial toxicity of being on a medication like this. So trying to work with their insurance to see what they may cover can sometimes dictate the prescription written, at least for me.
I almost always start with a beta agonist. I just feel like the side effect profile is definitely safer and more tolerable. And then I always tell the patients, if for some reason their insurance doesn't cover it, just give me a call and I will switch the medication. In which case, I still go with the anti-muscarinics that have a safer profile and more tolerable profile.
Yeah, agree.
Which one do you typically go for if you're doing the anti-muscarinics?
So usually for older patients, I almost always prescribe trospium to start because trospium is a larger molecule. It's less likely to have any problems with cognitive side effects such as memory loss or dementia. It depends. If a patient has more bowel effects, for example, if they have constipation, I definitely try more selective medications such as like fesoterodine or solifenacin. If they have loose bowel movements, sometimes I'll prescribe darafenacin, which was actually developed originally for people who have IBS.
I think those considerations are very important. And I think the other thing that comes up often is patients we prescribe the beta-3 for initially, but they want an add-on therapy. And I think my go-to is trospium as well. And I think it's just out there in the literature, the lay literature for our patients to read, and they do read it and they comment and show it to you, that it's less likely to have cognitive effects.
Yeah, that's a really great point.
Yeah. And so if they come in and they've got these concerns about, dementia, how do you help them kind of balance that concern about the dementia and, the medications? Do you just say, we'll try it and see what happens, or?
I let them know that the dementia data is an association, and that while there are a lot of patients with dementia who may be on these medications, the actual causality has not been really established, and that's mainly with the more simpler drugs like the oxybutynin and generics, fast acting, so that if there's no data showing that trospium will lead to dementia, there is a possible association that we have to counsel you on that, but it should be safe.
That's a really good point that you brought up. And I think it's really just been in like late 2024 and 2025 that there's been more emerging evidence to suggest that maybe we're overcalling this association, and we probably need a better look. And, there's been publications in the last year that the beta-3s may be in fact implicated as well. And I think the story's yet to be entirely told, but some of our international colleagues in this space who we all love and admire have written on this topic saying that the story's not done yet, right? We're still looking to understand what these drugs are doing in the dementia space, and if they're really making a difference, or if it's the underlying medications or the underlying disease or just aging.
And then there's also a lot of shared decision-making that goes into these decisions, because overactive bladder is really, for the most part, a quality of life condition.
Absolutely.
So the patient often will say, well, my insurance coverage isn't covering the beta agonist, but I would like to try another medication. I don't care as much about those potential long-term side effects. I would like to try the less expensive alternative. That's up to the patient as well. And you can counsel them about the risks and benefits, but some of them really would rather try the anti-muscarinic medication, especially if in the short term. I usually tell them there isn't necessarily any evidence that in the short term it would cause any memory or dementia issues. It's more in the long term, greater than 3 months.
Yeah, I think there's so much to cover in our office visits. Like, I think getting through all that shared decision-making is always such a challenge. We've started to send patients materials before their visit. I don't know if you guys are doing this as well, but especially when they come in for a diagnosis like OAB, it's like, like there's so much for them to hear, and like to try to get to the point with which they've understood and you're making a decision together is hard to do in 15 minutes.
I also always send them with a pamphlet. I go through all the options, and I always send them with usually like the AUA OAB pamphlet that's fairly comprehensive.
Yeah. There's just so much information to go through in like one visit. You can't expect patients to come out and remember everything we just talked about, And we talked about some of the side effects like constipation, dry eyes, dry mouth. Are there some management strategies that you bring up with patients to help manage those side effects, so they don't have to just, once they have a side effect like that, they don't just stop taking the medication?
I actually like to talk to patients about their nutritional intake, make sure they have a decent balance of soluble and insoluble fiber. If they have developed constipation, make sure they're drinking enough water. But if it's really the anticholinergics really causing the constipation, then I usually will have them try to switch over to the beta-3 agonist if it's feasible.
I often recommend agents like Biotine, which is a mouthwash that will coat the lining of the mouth, and especially right before bed, because I think a lot of people will drink more right before bed or overnight, and that's driving the nocturia. And well, there's nocturia is so multifactorial. I think for people who have OAB, it's bothersome, and if you could just try to eliminate some of the water intake right before bed, it could potentially be helpful. So I talk a lot about those mouthwashes before bed.
And some people swear by lemon drops or chewing gum as well. Chewing gum does promote the saliva in your mouth too, and not everyone likes to chew gum.
Yes. Yeah. And so, we're talking also about some of the newer medications, and we find that a lot of patients do really well with them, don't have as many side effects. But of course, you mentioned the insurance hurdles and getting the approvals. Are there any other kind of things we can do to kind of help patients get through that? I know, I think Gemtesa has some sort of program that's, for patients who are low income, who help them kind of get those medications approved, or get at least some short-term medication trials.
Yeah, I utilize that for the 1 month free supply with the Gemtesa. Every time I prescribe it, it usually takes my office at least that long to get through the paperwork for prior approval. So it's really nice to tell the patient, we're going to do this in the meantime. You'll at least get the 30-day supply, which I think is enough for most patients to judge. And then now you mentioned the generics. I try to find coupons. I don't know if you're doing the same thing.
Yeah, I've had patients actually go to Canada to get their Merbegron too.
So we send a lot of patients to Mark Cuban Pharmacy, and Mark Cuban has several medications. You have to keep on checking the website because they keep on adding medications quite quickly, and the price sometimes seems to fluctuate a little bit too. So that's been a really helpful option. It makes, for example, trospium is extremely affordable.
Great. Cool. After trying all these different medications, how do you and your patients decide to stop trying medications and move on to other treatment modalities?
So I think we all know this, but in 2024, when we redid the overactive bladder guideline, we stopped the tiered treatment, right? So we no longer have to progress from first line to second line to third line. We sort of got rid of that. And now the goal is to sort of share all those treatment options up front and really let the patient and share decision-making, take them down the path they want to go. But it is a lot to cover, and it's a lot to sort of meet someone the first time and be like, hey, I'm going to take you to the OR for a, sacral nerve stimulation. So I think for me, I still kind of present them in a tiered approach, but let them know that, listen, not everyone has to sequentially go through them. And when you're not satisfied, let's maybe move on.
Yeah.
So I go through the menu every time with them, the different treatment options, the different categories, and we talk about what they're happy or unhappy about. And I really try to focus on that aspect.
Yeah. So I usually, when I talk to my patients about this, I say, it's not so much tiers as different varying degrees of invasiveness of treatment options, right? So there's non-invasive things, like sometimes we talk about pelvic floor physical therapy, there's medications, and then there's procedural types of things. And sometimes you feel patients out and say, which one would you want to do? You want to stick with something less invasive? Do you feel like you take too many medications already and you don't want to talk about medications at all? In which case we should talk about some other, more advanced therapies like procedural types of things, right?
Yeah.
I sometimes let patients know when they start a medication to not be disappointed that the majority of patients may need to stop the medication, whether it be lack of efficacy, cost, or a side effect. And so sometimes not to set up disappointment, but just to at least be aware that that's a possibility.
Really pragmatic, because I think all the literature has shown us that they do stop, right? Persistence on medication is pretty low, and somewhere in the range of like 20 to 25% for the anti-muscarinics, and maybe as good as 40% in the short term for the Beta-3s.
And for the older patients, studies show that they're more likely to discontinue the medications for multiple reasons.
Yeah. And then since, once patients stop doing the medications, do you find that there's any sort of roadblocks or anything that you come across when we're moving on to more advanced therapies like chemodenervation or neuromodulation techniques?
If the patient, sometimes the patient stops the medication just because they weren't that bothered to start. So again, it's very shared decision making. There are patients that say, actually, I found the side effects of medication to be worse than my problem itself. And I've learned with the treatment strategies you taught me that I don't actually need anything else because I'm happy. It all comes down to shared decision making. There are patients who try medication and find the side effects to be so burdensome that they feel that with the lifestyle and non-invasive treatment options that we've taught them, that they're actually quite happy with and can deal with their baseline. There are other patients that are so bothered by their urinary incontinence, frequency, urgency, that they are happy to try the other treatment options. And we always weigh repeat visits, invasiveness, potential side effects of the treatments, and then usually we're able to come up with a treatment strategy.
Doreen brought up a really great point, which is for a lot of our patients, when we're talking to them about medications, we don't just throw away all the behavioral stuff. We really talk to them about doing all of this with maybe the goal of purposefully coming off the medications and just being able to have a lifestyle change or improve pelvic floor strategies to improve their symptoms. And so I think some people get to the point where they say, I think I'm doing really well. I can come off my medication. But to answer your question about obstacles, I don't really perceive very many obstacles. I actually have an easier time getting botulinum toxin approved than I do the Beta-3s. I don't know if that's your experience in New York.
That's my experience too.
Yes.
Yeah. I find a lot of patients are on medications for, sometimes it could be multiple years, and they've tried 3-4 different medications and they didn't know the minimally invasive options exist. Yeah. And those are the patients you really can present all these great, like Doreen said, menu options, right? And they get really excited. And then you have the patients who are they hear it and just a little gun shy. They're like, oh, I'll take this information and read about it. And I try to just give them time to process that.
Yeah. And I find that a lot of my patients kind of go with, am I bothered enough to want to do something more invasive?
Exactly.
Yeah.
Sometimes they hear about how frequently they may have to come back with botulinum, and they say, well, I don't know if I want to come and pay for parking.
Yeah,
Pen medicine for
Yep.
in particular with PTNS, patients can't
Yeah.
make the weekly visits all the time.
Yeah. But there are some patients who actually like it a lot. They feel like it's a more like holistic kind of approach, more natural approach. So they seem to really like that. But again, if it's super time consuming, it might not be something that's feasible to continue. I hear the same thing about Botox from my patients as well, in that they're like, well, I don't want to come back even that often, every 3 to 9 months, however long it might take to wear off, and to get like a more invasive procedure with a cystoscopy.
Yeah, it's shared decision making. Every person has different priorities.
Yeah. What do you think about using different combination of therapies together with multiple different modalities to manage persistent urinary symptoms?
So I definitely have many patients that are on combination therapies. For example, even the patients that do extremely well on Botox will often start taking their overactive bladder medications once the Botox starts wearing off. There are patients who continue the entire time because they do feel like the Botox plus the medication work better. And I have many patients that are on sacral neuromodulation that still insist on taking their medication. I always give them the option of discontinuing, but you'd be surprised. A lot of patients really feel that multiple modalities work better together. What do you think?
Well, I think especially in men who have an element of BPH or they have urge predominant mixed lower urinary tract symptoms, I'll commonly use an alpha blocker in combination with one of the OAB specific agents. And I think the initial literature on combination therapy with, I think they used tamsulosin and an anti-muscarinic suggested that there was complementary effects and patients did better. Some of the later data suggests that maybe the anti-muscarinic is not adding as much, but then the Beta-3s came on. Alpha blockers plus Beta-3s really do look to improve a lot of the lower urinary tract symptoms in men. So that's sort of where I've been gravitating lately in my male patients.
That's actually in our updated OAB guidelines as well.
What do you do for patients who come in and they have BPH symptoms? They're not emptying their bladders that well. They start to do a little bit better on like tamsulosin. How do you counsel them about adding on like a anti-muscarinic or a Beta-3?
I think if they go from incomplete emptying and now they're emptying better, I'll be more willing to start a Beta-3 for their urge symptoms. I might try to wait a month to 3 months just to see sometimes if there's maybe some bladder remodeling theoretically, but I think it's a very good combination.
Yeah. Certainly, I monitor their emptying. Like every time they come in, I want to know like what's their PVR. Because it factors in, right? I mean, if these patients are all their complaints are like, I go frequently, I go urgently. So if you're not getting it out every time you go, it's probably contributing to some degree.
Yeah, then your functional capacity of your bladder is much smaller than it actually holds.
Yeah.
And I think, would you all agree, I definitely would gravitate to a Beta-3 as opposed to an anticholinergic in that type of patient.
Yeah, I think the evidence is supporting that at this point in time as well. And we want to always try to practice evidence-based medicine. But I think intuitively, it makes sense as well that would probably be the better combination. But we didn't really talk at all about PDE5 inhibitors and what they can add
The daily.
to the mix. And certainly in men, we have more data, but the use of daily tadalafil has been shown to improve a lot of the lower urinary tract symptoms in men. And, we don't really know the potential benefits in women, but it would be really interesting to start looking at women to see if we could get, complementary mechanisms of action without overlapping side effects to really try to more thoroughly treat these women who are bothered.
That's a great point. The interesting part about daily tadalafil in men is that it does not improve flow rates at all.
Yeah.
So theoretically, if it's not improving flow rates and really treating BPH, there should be an effect on women's lower urinary tract symptoms as well, because what it really does work on is frequency, urgency, and the lower urinary tract symptoms that don't have to do with flow.
And Doreen brought up a great point. Mark Cuban Online Pharmacy, the PDE5s are now very affordable on that website. So it would be accessible for the patients too.
Yeah. Have you, any of you ever tried the PDE5 inhibitors for females? No.
I have not,
I have
actually.
not.
I guess particularly, I wouldn't have thought that they would be covered by the insurance. And so that's probably the main reason I wouldn't have tried. I don't want.
I
a
mean, I think they
patient
have been
to-
used in the sexual dysfunction space. I just don't know how commonly they've been used for lower urinary tract symptoms, but we should probably look back at some of those studies where the primary endpoints were sexual dysfunction related and see if the secondary endpoints were measured and what things might look like.
Yeah. And then also going back to, we're talking about men and the urinary symptoms with Flomax and like an OAB medication. What about moving on to more advanced therapies for men with combination therapy of OAB, Flomax, and therapies?
I mean, men are challenging, right? Because if we want to give them Botox, we want to like move on and offer botulinum, but I do worry more about the incomplete emptying in my male patients, and I want urodynamics on all of them before I'll think about botulinum. I don't feel the same way about sacral or tibial nerve stimulation or PTNS because I don't think it's going to make them have any more difficulty voiding.
Same. And there are lots of men who have had prostatectomies for cancer reasons, who've had radical prostatectomies, who really do benefit very well from Botox, particularly those patients that have been irradiated, have these small, poorly compliant bladders.
How do you counsel your patients who are getting Botox on like the risk of retention? Do you teach them how to self-catheterize beforehand? Do you just tell them it's a possible risk and then proceed as planned and see what happens?
I think they're starting PVR. It's really, we always say PVR, but it's really about their voiding efficiency, right? Because if somebody has a PVR of 100, it's really different if they peed 50 and their PVR is 100, or they peed 600 and their PVR is 100. So it's really about their voiding efficiency. Yeah. But certainly when that number is looking poor to me and they're really not very efficient, I'm talking about CIC ahead of time. And some of the people you can tell, they're going to have a lot of trouble with it. So I will go the extra step and have them see the nurse learn intermittent catheterization ahead of time.
I probably also steer the patients with incomplete bladder emptying a little more towards tibial nerve stimulation or sacral neuromodulation.
Yeah. Generally speaking, I think what Ariana said is that the starting post-void residual is going to be the most important deciding factor, and if they are willing to take on that risk of CIC or a catheter, then I will share decision-making. I will offer that to them.
Well, there's the risk of falls too, and the risk of morbidity, mortality, hospitalizations with OAB and incontinence in the elderly. There's that aspect too.
So I think your question may be more like if you have older patients who have like an underactive bladder, how do you counsel those patients in terms of the overactive bladder medications, and the risk of developing retention and things like that? For our older patients who may have things like an underactive bladder, who may not be able to empty their bladders as well, how do you counsel your patients on, treatment options for that?
Yeah, I think that's a very good point. So a lot of women, as they age, they develop both the overactivity, right? Some involuntary bladder contractions, but during volitional voiding, they actually have a low contractility, right? So they've got this detrusor overactivity with impaired contractility. And these patients can be really difficult to treat. I think you can use medications and you can use them safely, but I do think my interval for follow-up is a little shorter than maybe my average patient, where I want to bring them in and I want to talk to them about how much symptom improvement they got, and then I want to monitor the emptying function.
Sometimes if the patient's able to as well, I get them to fill out a voiding diary. Sometimes patients like this, they don't void very well in the office, but at home they're doing really well. Yeah. You can kind of tell because the patients that are voiding well, they don't have urinary tract infections. Like those patients must be voiding well at home and just not in your office.
And it's sometimes related, but for older female patients, I'm often introducing vaginal estrogen into the picture. And I let them know that there's theoretical and some studies showing that there's benefits to voiding symptoms. So we introduced that.
Wei, it's a great point and probably something we should have brought up earlier, but you're absolutely right. I mean, nobody has a study showing the complementary action of estradiol in the vagina and a beta-3 or an anticholinergic, but we all do it. all the time, right? We're
Mhm.
using it all the time. And we know that the genitourinary symptoms of menopause are improved with the estradiol cream. We know the OAB symptoms are improved. And there's so much overlap. We can barely tell the difference between these two conditions. That is a great point.
Yeah, I find that some of patients who come in with urinary tract infections, like vaginal dryness, burning, that sort of stuff, sometimes they have a little bit of like bothersome urinary frequency symptoms, and they're not that bothered by it. But once they get treated with the vaginal estrogen, they say actually everything got better.
Yeah.
And so
It's
I
very
often will
rewarding.
Yes,
It's
so I often
real.
tell patients it can happen, and so we can just fix one thing first and see if your symptoms improve. If they do, fantastic, great. But if they don't, we've got lots of other options available, right?
It's a second study we need to make.
I know.
I think we all start everybody right away, probably. I think all of us all treat the genitourinary syndrome of menopause right away, in addition to the overactive bladder. That is hard to sort out which is which and what the overlap is.
Yeah, especially when patients come in after a string of urinary tract infections and you're trying to parse out how much of this is sort of a little bit of chronic inflammation from what they just went through and how much is going to improve with time and how much is now the onset of overactive bladder. And I think that's where getting them on vaginal estrogen, trying to wait it out a little bit, or maybe saying, let's introduce an OAB med, but with the goal of coming off it in a short period of time when we get this estradiol cream up to speed.
Yeah. Well, I was going to ask, we mentioned earlier about underactive bladder, and women who have trouble emptying their bladders. How often do you go on to do urodynamics first before even starting medications?
I think if the patient has a very high post-void residual, I definitely do. There are also patients who have a very positive cough stress test. But even those patients, I often will start a medication first. I think usually if they've started one treatment option and they have not done well at all and they've had no benefit, then often I will counsel the patient on moving on to another therapy or doing urodynamics if I think it's helpful. And I often will tell the patient, well, we can try options and see what helps, or we could do testing. And I do actually leave it up to them.
Yeah. I think we all practice in like tertiary care centers, so it's probably not super common that we get that uncomplicated woman who comes in. So, a lot of times I'm dealing with a patient who already had a sling, or they had pelvic floor surgery of some kind, hysterectomy, bowel resection, something. So I may order urodynamics, but like Doreen, I'll often offer initiating a drug at our first visit if they're interested in that, and that's part of why they came, really trying to read and understand what brought them in that day and what door prize they're hoping to walk away with.
Yeah, that's a great way of saying it.
Yeah.
As we're wandering into this obstructive voiding domain, I just wanted to ask the group, how often have you used tamsulosin or an alpha blocker in women, and have you seen success?
I think studies show the success rates are fairly low, 30% or less. But then I often will start people on it and I'll tell them, well, it's up to you. We could try it. There's no downside. Really, the side effects of an alpha blocker are very minimal with a very small potential for dizziness.
Yeah. I think when initiating an alpha blocker in women, and I do this, even in the MS population where you may have a harder time explaining why it might work, is because there's this huge placebo effect in all the drugs we give for lower urinary tract symptoms, right? There's this huge, like when you look at some of the OAB studies, it's incredible how well the placebos work. And you're like,
even for Botox injection,
Botox,
placebo
like,
works great for both. Like saline injections into the bladder, they actually work really well.
So for our individual patient, if it's the placebo or if it's the drug, it doesn't
matter.
really matter, right?
So it really doesn't matter.
Sometimes as we're working through, I'm trying to teach them pelvic floor relaxation strategies to promote emptying. I'll say, listen, we're going to give you this drug. We're going to try this in the beginning, but our goal too is to get off this. But let's work our way through PT and see if we can actually relax and work on, strategies to empty better.
Yeah. I wonder if a lot of this is also just giving patients like the feeling that they're in control, right? That they have something that can help them, whether it's, physical therapy exercises or medication that kind of makes them feel like, if I take this, things are going to be better.
I mean, that would work for me. I want to be in control of everything.
Yeah.
The other thing is treating the constipation. So I often will give medications for constipation if they're constipated. That does help a good number of these older patients with these underactive bladders empty better.
Yeah, yeah. And I think it's also helpful as well to counsel them on, techniques to help with constipation, even if they do get the side effects, with the overactive bladder medications. You don't have to stop the medication just because you got constipated. There's other things you can do to fix the constipation.
Yeah. One of the other things we learned so much about when doing the overactive bladder guideline was how much other comorbidities impact the bladder and a woman's perception of their bladder, and some of the things that we've known for a long time, like obesity and other things like anxiety, and how addressing some of those things at the same time can improve how they perceive their bladder, which is really what it's all about with OAB, right? It's really what they think.
And there are certain limitations too. I have so many patients who have severe peripheral edema and they only leak at night. And I explain to them that during the day, they store the fluid in their legs because their legs are lower than their heart. When they lie in bed, all that fluid goes back to their body. And there's only so much medication can do because they're going to be producing massive amounts of urine that they will have to urinate out. And people, even if they're not improved by the situation and are not willing to wear support stockings, they somehow are happier.
My pulmonology colleagues love me because every nocturia patient, if they snore, I send them for a referral.
And I wonder what percentage have sleep apnea. It's probably pretty high when you have snoring and nocturia.
Yeah.
Yeah.
Yeah, I wish I knew the number, but that's got to be pretty
Yeah,
high.
that's a good point. You can look at your referral patterns
Yeah.
and look them up.
All right. Well, I want to thank everybody for your time and everybody for your attention.